In this video, I will cover the clinical presentation of lateral elbow pain, commonly called tennis elbow. Expect to learn the following: clinical signs of tennis elbow presentation, two common causes of tennis elbow that most providers completely miss, proper load management for a tennis elbow injury, and how to successfully resolve the tennis elbow without drugs, injections, or surgery. For those of you that don't know me, my name is Dr. Matt Maggio. I am a soft tissue injury treatment expert. My focus is on diagnosing and treating adhesion, also known as scar tissue, and reducing inflammation from chronic injuries without the use of drugs, injections, or surgeries, which does lead to a significant increase in overall functioning, flexibility, and long-lasting pain relief. I'm also the program coordinator for Adhesion Release Methods, where we teach manual therapists a new treatment system that eliminates the frustration of not getting consistent results so they can help more people get out of chronic pain, all while working 50% less and easily doubling their income. All right, understanding tennis elbow, clinical signs, causes, and proper treatment. Let's get right into the video. So, some clinical signs of tennis elbow. I don't like the name tennis elbow. It doesn't really tell us a whole lot of things. We have these things in the injury treatment world, the musculoskeletal treatment world, where certain areas where things hurt, we just call them those things. So, if there's any pain in the lateral part of the elbow, it's named tennis elbow. Doesn't really tell us anything. We always want to have a tissue-specific diagnosis of what's going on, because if we don't know where the problem is in the first place, we're never going to be able to fix it. So the thing that we teach a lot in our methods is taking a proper and thorough detailed history. There's a lot of questions that we ask, because if you can't figure out the problem clinically, there's no way you can actually fix it technically with your hands if you don't ask the right questions. So there's some really telltale signs of tennis elbow presentation. I'm just going to call it tennis elbow for the rest of the time just to make it easier. One is just going to be age, where they're feeling it. A lot of times it doesn't matter as much with age. Sometimes if they are a little bit older, I'm thinking of more of what's called a degenerative component, especially on the tendon. I'll cover that a little bit further in the video. Next is just going to be symptom location, where they're actually feeling it. So with the tennis elbow, it's going to be right out there on the lateral part of the elbow. And when I'm looking at the elbow, I'm always thinking of it in an anatomical position. So where the arm is straightened out. So that would be everything back through here. A lot of times with a tennis elbow, you might see some symptom quality as like tight, aching, throbbing. Sometimes it can just feel restricted. It can be sharp with particular movements if it's more of a chronic type of thing. Next thing is just going to be symptom intensity, like how intense is it? So the way I scale my intensity, and I say to clients, I say on a scale of 0 to 10, 0 being no pain, 10 you wouldn't even care if we cut off that area. What is the worst the pain has gotten? Then I also like to know, when's the last time they had an episode that bad? Then I also ask, what have they felt that over the last 30 days on average? So I'm trying to get an idea, am I dealing with a chronic thing, a flare-up, a more acute type of thing? This really gives me some ideas about what I'm thinking about in my differential and what I'm trying to diagnose. Definitely next thing is, what makes it worse? A lot of times when there is this injury in there, using it can make it feel a lot worse. And then I also want to know, is there anything that makes it feel better? Maybe if they ice it after, maybe if they stretch it, maybe if they roll a lacrosse ball on it, maybe if they wear a brace. I want to see some type of that component as well. I always want to see something makes it worse, and then something does make it a little bit better. Another key is just accidents or trauma directly to that area. A lot of times when there's no direct trauma in the area, a lot of times I'm thinking it's a compensation, a lot of times coming from farther up the chain, maybe up in the armpit, in the neck, throughout the nerves in there as well. Next thing I'm going to look for is just recreation and activities. Like, what do they do? Do they actually play tennis? Do they have a job where they're on a computer all day? Do they do some type of repetitive motion with their job? All these things, I'm really putting it together and really collecting the data so I can start to think critically and start to figure out what I'm dealing with. So one of the most common causes of a tennis elbow presentation is actually called an entrapment of the radial nerve. So basically, nerve entrapments are a really big deal. I'd say 85 to 90% of my treatments are focused on finding and fixing nerve entrapment. So nerve entrapments start to form over time. So when the muscles around the area, usually in the muscles in the ligaments, in the fascia, the muscles themselves, they get overworked. And when they get overworked, they don't get enough blood flow, they don't get enough oxygen. It causes the body to start this whole feedback loop of hypoxia, and it starts to lay down these immature collagen fibers. And what happens with that is it forms this stuff called adhesion, also known as scar tissue. It's like glue, gets in there, gets bigger and bigger and bigger. And then eventually what happens is it gets stuck to the nerve. Nerves are built with about 15% of extra slack to keep them healthy. But when an entrapment occurs, it gets stuck there and it starts to pull. So when I do have a radial nerve entrapment, I'm definitely going to see one here in the lateral part of the elbow. The quality, though, when I'm having a nerve entrapment is going to be more like a numbness or aching or a burning or tension. And then usually with intensity, it's not too bad. It usually ranges anywhere from that 3 to 7 range. It really doesn't get up to like that 8 or 9 out of 10. It's more of like an annoyance. And get like that zinging type of feel if that nerve is pushed just right. Definitely what makes it worse is anytime they actually use it, it does get better with rest and a lot of times when it's not active. Another thing I'm also looking at is there a history of trauma, especially to the neck, the shoulder, or the elbow itself. If there's no actual trauma to the elbow, a lot of times I'm thinking that nerve entrapment that's occurring in there is actually coming from higher up. Then also just looking, like I said, at their everyday activities and recreation. What are they doing? What type of environment are they living in? Are they overusing this area? All this information really gives me a better idea of the radial nerve component. But a key one there, what I talked about, is definitely going to be that quality, that numbness, that aching, that burning, and that tension. So when we do find a radial nerve entrapment, there is a treatment protocol to break it down. One thing I always talk about too is we want to understand, was there trauma or not? And most of the time there wasn't like a whole lot of trauma. I don't like to treat like a lot of trauma. I don't like to treat when like maybe someone fell on it or they had an accident or a fall on that, because a lot of times there's more damage in there that can actually be addressed by just treating the soft tissue. What I like to see is that kind of came out of nowhere. It kind of slowly ramped up. It wasn't like one day woke up and this is just awful. It's just like it gradually started to get worse as time goes on. And I like to see that chronic component of like 3 to 6 months. So the first area where I do start to address this is along the track of the radial nerve. The radial nerve is actually the biggest nerve in the upper extremity. It goes a long way, supplies a lot of muscles throughout its path. And where it begins is up in the nerve roots at the scalenes, and it can get caught anywhere between the anterior and middle scalene or the middle and the posterior scalene. And it comprises all of the levels of the brachial plexus, which is going to be C5 to T1. For that, I do a manual treatment where we get proper depth and tension into the nerve, have the client go through a full range of motion, hold that nerve back as that adhesion pulls away, that frees it up. Next area that we do start to look at it is down in the subscapularis, specifically on the brachial cords, and it's going to be on more of the outer portion of there, back through like down by the triceps in there as well. And when we go in there and treat that, what we want to do is normally when I'm treating that area, I kind of bring the arm back like this. With this one, I actually bring it back and then I do some internal rotation. That's going to get in there and break that down. I'm holding proper depth, proper tension on that nerve as it goes through a full range of motion. The thing with these nerve entrapments and these treatments are you do not want to be aggressive with them. They don't need a lot of pressure and a lot of depth. They need just the right amount of tension to break it down. You can also see it as well in the triceps junction and where the brachialis comes in, right there where it comes underneath the lateral part of the elbow. For that one, I do like to do an instrument type of treatment with that, where we can go in and get some of that superficial stuff. It's actually pretty easy to get in there and feel that grit of that adhesion right around the nerve. Give you some good feedback on the instrument as well that you're actually treating that area. Then the last area where we treat it is actually going to be in the supinator. That's where the most common entrapment of that radial nerve occurs, is right on that supinator in there. Basically what we do is we put it in a shortened position. We find that area where that nerve is stuck and it's not bowing. Depth, tension, have the client go through a full range of motion. That breaks that down. This is usually going to be the most common presentation, especially if I have someone like a little bit younger, maybe like anywhere from like the 20 to like 45 or 50 range. It's going to be a radial nerve entrapment that's going to cause a lot of those issues. So I usually start there and treat the radial nerve entrapment. And a lot of times that clears up the majority of that tennis elbow presentation. If it doesn't, then we're thinking there's another problem. The next problem is what's called a tendinosis. So most people think of this idea called tendinitis, and basically I have this slide over here in this picture. A tendinitis is a healthy, normal muscle, but it's some type of inflammation happening in there. A tendinosis is actually a degenerative component of the tendon. So basically, if you think of a tendon, it looks like from a box of spaghetti. It's like, say you had a box of spaghetti that isn't cooked yet. It's really tight and really strong. It'd be hard to break that. That's what a normal tendon looks like. A tendinosis, if we looked at it, it kind of looks like cooked spaghetti where it's not right. It doesn't move right, doesn't get enough blood flow, doesn't get enough oxygen. So a lot of times when there's adhesion buildup around the nerves in the muscles can't generate the force they need to. It makes that area weaker and less flexible. The force has to go somewhere, and it ends up going to the tendon, and then they start to get some of that degenerative component in there. Tend to see it in an older person. Definitely symptom location is going to be right on the bone there, right up by the elbow where it just doesn't feel right. A lot of times they might say it's kind of like sharp and stabbing and just aching all the time. Something very interesting about a tendinosis is it actually feels worse when they don't use it, and it starts to feel better when they warm it up, which is actually dangerous in the long term for the client because they think if they're warming it up and it feels better that it must be moving better. But what happens is when it's at rest, it doesn't get that blood flow, doesn't get that oxygen, all the waste product builds up in there and it can't get out to where it needs to go. They start moving it and they think it feels better. Sometimes with some accidents or trauma, you might see some damage to the tendon. Definitely recreation and activities. Like I said, if they play some type of racket sport where they're gripping or something with their job or they're on their computer all day long. But a tendinosis is a really big deal because usually when someone does end up having a tear of the tendon, it started with a tendinosis. It doesn't just happen overnight. People don't just blow out their tendon and all of a sudden it's very strong. It just repetitively gets beat up over time. And 97% of them that tore were a tendinosis in the first place. So tendinosis treatment protocol, basically what we need to do is we need to reduce the adhesion using manual and instrument-based treatment protocols, basically what I talked about, getting that radial nerve to clear up. Then we need to reduce the daily load on the tissue. Basically when a tendinosis happens, it's because they're doing too much. An injury in the shortest presentation is on one side is load is what they do, capacity is what they can take. When an injury happens, load exceeds the capacity. So we have to limit their load from where we are. That can happen with some bracing if you need to, just letting it kind of chill out. Then once we do that and they're able to take it easy and let it heal up and we're breaking down all the adhesion, getting it functioning better, then we can actually go in there and treat the tendinosis directly with an instrument right on that area. You basically have to peel away some of these extensor muscles and go in there and break that tendon down with an instrument. That's going to regenerate some of that tendon, help it start to grow and start to heal. Then lastly, what we need to do is what's called an eccentric loading of the tendon. So basically what we do is we have a very light weight and we have the client go down really slow for a 4 count, 1, 2, 3, 4, and then we have them bring their hand back up. And what that eccentric loading is going to do is it's going to help to regenerate that tendon as well. Now, if we try to load it with eccentric exercises before it's healthy, it's kind of like trying to fix a cavity by brushing and flossing your teeth. It's not going to help. It's going to make it a lot worse. You have to follow this order of operations going through everything. So what about bracing, taping, and strengthening? One thing that we always have to consider is the idea versus cause versus effect. And a lot of times when it's hurting in the elbow, it's not the actual true cause, it's actually the effect. So if you go in and you brace it and you take some of the pressure off of there, but you don't fix anything, you're going to continue to load that problem even more. And a lot of treatments out there, they really only improve the symptoms, but they don't improve the function. And when they don't do that, it's going to cause a lot of issues. It's actually very dangerous. Just because the client feels better doesn't mean they're better. It's putting them in a bad situation that can cause bigger problems down the road. So I'm all for bracing or taping if you're doing it to just help the client reduce their load. If you're bracing them or you're taping them and they're still doing all their activities and still beating that area up, don't do that. It should just be there for load management in between. Maybe they're like, hey, I got to work on the computer all day. I'm like, okay, well, wear the brace in between. That's going to help this and help it go from there. But don't throw tape on them or a brace and be like, yeah, go out and do all the stuff that you were doing before, and it's going to be all magically fixed. That's not going to happen. The biggest thing is we want to follow what I call an order of operations and strengthen in the right order. So in order to fix any problem, first is we have to restore range of motion. That's by finding and fixing the adhesion. Then we need to balance some strength with some corrective exercises. Then we need to increase the strength with overall global motion. That's what we need to follow. So if you start by strengthening before you fix anything else, you're going to put the client in a bad spot. Their problem isn't going to get fixed. It's going to get worse, and they're going to end up on the surgeon's table getting a treatment and a surgery that's only going to temporarily make it feel better, but it's going to be a lot worse down the road. So that's all I got for you in the video. Appreciate you watching. Share any insights you might have gotten in the comment section below. Please share this with other providers that you know it might help. And lastly, go download our free training modules. The links to that are wherever you're consuming this. We